Hello, everyone. Welcome to MyIBD Learning. Today, we will learn and navigate the treatment options that you may have while managing the signs and symptoms and inflammation of inflammatory bowel disease. One important note before I begin this program, that the information that I will be providing you during this program is current as of the date of recording. There may be new medications coming in future, so always visit the website www.crohnscolitisfoundation.org or contact the IBD Help Center at info@crohnscolitisfoundation.org for more information and resources. I'm Tauseef Ali. I'm a medical executive director at SSM Health Digestive Institute, where I also direct Crohn's and Colitis Center of SSM Health. So let's see what are our objectives. What are we going to discuss today and address different topics? We are going to look at the risks and benefits of medication, surgery, and integrative treatments in inflammatory bowel disease. We'll also look at the impact of treatment adherence on disease management and quality of life. And we'll also talk about how do you talk with your healthcare team about your treatment plan and the importance of shared decision-making. So when we are offering treatment or considering treatment options in terms of medical therapy, we have certain goals that we keep in mind. We want to induce remission, meaning we want you to have symptom relief, symptoms such as abdominal pain, diarrhea, bleeding to go away. Once we achieve that goal, we would continue the medical therapy so that we can maintain that remission. And once you are in remission, we try to monitor your disease. We want to make sure that it's not progressing and causing damage. And we will also take some preventive steps to prevent complications and optimize therapy. And this will all lead to improved quality of life. So there are different treatment options. When you go visit your doctor, he or she may be prescribing you, suggesting you, and recommending you different treatment options. And those may include over-the-counter medications, some prescription medications. We may discuss about surgical options, and the discussion may go to complementary and alternative therapies. So let's review some of over-the-counter medications that we may suggest or recommend to our patients. Remember one thing, over-the-counter medications usually address symptoms like pain and diarrhea. These are not the medications to help control the inflammation or heal your bowel. So for symptomatic control, we may prescribe you antidiarrheal medications, laxatives, or some pain relievers. For diarrhea, we may suggest loperamide, Imodium, or diphenoxylate atropine, which is Lomotil. Lomotil is typically a prescribed medication in the United States. For fever and joint pains, we may use acetaminophen. Sometimes you may wonder about using NSAIDs like ibuprofen, naproxen. We typically prefer acetaminophen over NSAIDs because if you use NSAIDs in a higher amount or for a long period of time, it can damage your gastrointestinal tract and can lead to increase in your symptoms or disease flare. In terms of prescription medications, we have different classes. We may have to give you antibiotics or other classes, for example, Amino Salicylates, which are typically used in patients with ulcerative colitis. For a short term to control your symptoms, we may have to use corticosteroids. And then we have the class of immunosuppressive medications such as immunomodulators, azathioprine, 6-mercaptopurine. Then we have biologics. We also have now biosimilars, and I'll touch base with you on that. And then a new class called targeted synthetic small molecules, which are oral medications that we have recently, that has been made available to us. So typically antibiotics are used to treat conditions such as pouchitis, which is an inflammation of the J pouch, and you get J pouch after your surgery for ulcerative colitis. Sometimes we use antibiotics when you are dealing with perianal fistulas, or you have abscesses, infections. And in some patients with inflammatory Crohn disease, generally it is not considered useful in ulcerative colitis. We have to be very careful when we are prescribing or using antibiotics because we don't want to develop bacterial resistance. Sometimes we don't want to use it because of the side effects also. And if you are using inappropriately antibiotics for many reasons or other reasons, then using it specifically for Crohn's disease or colitis, you can get complications such as Clostridium difficile, which is an infection that can happen because of the use of antibiotics. So you have to keep that in mind. The next class is Amino Salicylates. They are used in ulcerative colitis. They are useful in preventing relapse and maintaining remission. They're generally very well tolerated. They are sometimes, we have now formulations which are used to release the medication to the specific area of the bowel. They're very effective in treating mild to moderate ulcerative colitis. You can use them as pills, or sometimes they also come in topical formulation, meaning you can use them as a suppository or enema. There are very few side effects. Sometimes in about 3% of the patients, they may be allergic or they may be intolerant to mesalamines or 5-amino salicylate therapy, and their symptoms may get worse. And that is the time when you may need to discuss this with your physician and see if you need a replacement to another alternative. The different amino salicylates, there are different classes depending on how the compound looks like. Balsalazide is one. There are different mesalamine formulations that are available in the market with different names. The last two names that you are seeing in this category, one is Rovasa, which is a mesalamine enema, and one is Canasa, which is a mesalamine suppository. Then you have olsalazine, dipentum, and sulfasalazine, also known as isilfadine. These are some other types of aminosalicylates that you use. Typically in the United States, majority of the patients get prescribed mesalamine formulations. Corticosteroids, they are very good initially to induce symptom relief, but there are a lot of risks involved using corticosteroids for long term. The risk of infections, sleep disturbances, mood swings, neurological changes, weight gain, skin issues, like your skin can become what we call papery skin, fragility in the skin, growth delays in kids, bone loss leading to fractures. So we have to be very careful when we are prescribing corticosteroids. Perhaps good for short term, but whenever we prescribe steroids, we always consider this as a bridge therapy to something that can be used long term. Different types of steroids. We have a budesonide, which is a type of steroid that works only in your intestines. It gets minimally absorbed in the system, so you have less side effects as compared to your other corticosteroids. Budesonide comes in Entocort formulation or Uceris. Uceris is a pill, but it is also available as enema. Hydrocortisone, it can come in different formulation. You can use it as a pill, you can use it as IV, intravenously, if your symptoms are really severe and you are getting admitted to the hospital, or you can use it topically where you can use it as an enema or suppository. You also have Methylprednisolone, which comes either in a pill form. You may have heard of Medrol dose pack, or it may come as IV infusion where you can give that during hospitalization or in the emergency room or in the IV therapy or IV infusion labs. Prednisone comes in a pill, most commonly used, where we give prednisone when you are having a flare and we are deciding what will be your long-term therapy. The next class is immunomodulators. It's been in the market. We've been using it for a long, long time. It's one of the older therapies for Crohn's and colitis. And believe me or not, that was one of the mainstay therapy many years ago before we had biologics in market. And if you recall, the first biologic in the United States came in market in very late 90s, perhaps 98, 99. So before that, the mainstay of our therapy was immunomodulators. So if you are getting steroids to help you, give you an immediate relief, many patients would then get placed on immune modulators. Usually it's taken along with some other medications also these days. For example, it may get combined with the biologic therapy to help you get a durable response and help you control the inflammation. And the data shows that once achieved, 70% of adults stay in remission for at least 1 year when they are on these immune modulators. But with time, you may lose response to it, or the drug may become not as effective as it was in the beginning. And also keep in mind that this drug sometimes takes time to become effective. Unlike steroids and unlike some other medications, these are very slow-acting medications, and sometimes it takes weeks before you can feel like it's helping you control your symptoms. There are some risks involved with this type of therapy. Sometimes, well, you have to use it weight-based because if you have a genetic mutation, and there is a test for it and that your doctor may order, it's called TPMT genotype. So if you have a TPMT, which is an enzyme that actually breaks down this medication when it enters your system, and when it breaks down, it actually gets broken down into an active metabolite or an active ingredient. And then there is one product that could be toxic. So depending on how active the enzyme is, you can either build up the toxic ingredient too much, that can cause a bone marrow depression, your blood count can go down, or you may not get effective medication also. So many times your physician will order this genotype, TPMT enzyme activity to see how carefully we have to use this medication. If you are a very slow metabolizer, maybe you need to avoid these medications or may need to use this medication in a smaller doses as compared to other patients. There are some other side effects that can happen. For example, you can get pancreatitis, which is very unpredictable. We call it idiosyncratic reaction, meaning we really don't know which patients will get pancreatitis. But if you have been started on this medication and now you are having abdominal pain, nausea, vomiting, and the symptoms are getting worse, immediately stop this medication and seek out help. You may have to go to the emergency room or call your physician, telling them that you're having worsening of your symptoms, and also describe that you were just started on this new medication. It can also happen during the course of this therapy. So maybe after a few months that you're now developing these symptoms. So pancreatitis is one risk that you have to be aware of. The other things, as we discussed, that sometimes your blood count can go down, sometimes you can get infection. Long-term use of this medication may be associated with risk of lymphomas. So you have to keep in mind these risks when you are choosing or selecting therapy. There are different types of immune modulators. Azathioprine is one of them. It comes in the market with the trade name of Imuran or Azasan. 6-mercaptopurine is another one, and methotrexate is another immune modulator, which is different than azathioprine and 6-mercaptopurine. Methotrexate, typically you can take it orally or you can give yourself an injection under the skin or into the muscles. Methotrexate is different than azathioprine and mercaptopurine. It is we don't check the enzymes to check the activity, and it has its own different risk profile. You cannot use it during pregnancy, or if you're planning to get pregnant, you must avoid methotrexate. Cyclosporine and tacrolimus are other immune modulators. They're not as frequently used. Typically, they are used when you are having severe disease or as a salvage therapy, or you're admitted to the hospital. You may get IV cyclosporine. And similarly, tacrolimus can also be given orally as pill or through intravenous through the veins when you are in the hospital. These are not very commonly used medication, especially the cyclosporine and tacrolimus. Now we come to the mainstay therapy, which is the biologics. They specifically block inflammation or sometimes they stimulate an anti-inflammatory process. They are made from living organisms and their products, such as proteins and genes and antibodies. The biologics that we use in Crohn's and colitis are monoclonal antibodies, and they interfere with the process of inflammation. There are risks involved when you use biologics, such as risk of infections. Sometimes you can even get infusion reactions or injection reactions. Rarely, you can also get psoriasis, which is it's kind of what we call paradoxical reaction, because many of these biologics are used to treat psoriasis. But sometimes we see that when we use biologic therapy, monoclonal antibodies, especially anti-TNF drugs, you can actually develop psoriasis as a paradoxical reaction to the medication. So a regular skin exam, self-exam, as well as a skin examination, either by your physician or dermatologist, is very important when you are on these types of medications. There are different types of biologics. In the past, we used to have only one class. So when we would say biologic, we would mean anti-TNF drugs. Anti-TNF drugs are type of biologics. These are the antibodies that block TNF, which is one of the inflammatory protein that causes damage and inflammation. There are different types of anti-TNF that we have now. Adalimumab, also known as Humira, used for both Crohn's disease and ulcerative colitis. Certolizumab, which is also known as Cimzia, which is used only for Crohn's disease. Then we have infliximab, also known as Remicade. Then we also have some biosimilar infliximab. They're used both in Crohn's disease and ulcerative colitis. Golimumab, which is Simponi, is used only in ulcerative colitis. Then we have another class of biologic or monoclonal antibodies called anti-adhesion molecules or anti-integrin therapy. One example is vedolizumab, also known as Entyvio. It's approved for both Crohn's disease and ulcerative colitis. Just like anti-TNF blocking the TNF molecule to block the process of inflammation, anti-adhesion molecules prevent the white blood cells or the T cells to enter the site of inflammation, such as your gut. So if you are using Entyvio or vedolizumab, it's actually blocking the entry of white blood cells into the gut where the inflammation is happening. Then you have another class called Interleukin-23 Antagonists. So these are the antibodies that block the receptor 12 and 23 and prevent the production of more inflammatory proteins. One such example is ustekinumab or Stelara. It's approved for both Crohn's disease and ulcerative colitis. There's a new class now, it's called Interleukin-23 antagonists. So not only we have 12-23 blocker, we have also now discovered that if you just block 23, you will get the results similar. So it's basically the 23 interleukin or the protein 23, interleukin protein 23 that actually is involved in the process of inflammation. So if you just block that, you will also get good results. And one such example that we have now is risankizumab, RZAA, which is commercially known as Skyrizi. It's been approved for Crohn's disease. Biosimilars are your biologic medication that is similar, near identical copy of an already approved biologic therapy, or we call it originator drug. And it has been found to be equivalent in terms of efficacy and safety. So their effectiveness to control inflammation, their safety profile is similar and equivalent to the originator drug. The examples that we have, infliximab DYYB, Inflectra, or infliximab ABDA, which is Renflexis, or infliximab AXXQ, which is Afsola. You can see here that some of these biologic biosimilars are FDA approved and are already being used in the United States. The last class that I'm going to share with you today is the targeted synthetic small molecule. This is a new class, and in this class we have 3 drugs: tofacitinib, Xeljanz, ozanimod or Zeposia, or upadacitinib, which is Rinvoq, and all 3 of them have been approved currently for moderate to severe ulcerative colitis. These are small molecule compounds that are broken down in your gastrointestinal tract after ingestion, and they are directly absorbed into the bloodstream through the intestines, and then they go inside your white blood cells and block the production of more inflammatory proteins. In case of ozanimod, which is Zeposia, it actually blocks the trafficking of your white blood cells or lymphocytes from your lymph nodes. They trap them in the lymph nodes so that they don't go to the site of inflammation in your gut. The benefits of these therapies are that you can take it orally. Most of them are once a day oral pill. They're very fast acting to achieve and maintain remission. Unlike in the previous class that we were using in the past, called Immunomodulators, that may take weeks before you will see the effect. Here the results are, you can see the effect faster than Immunomodulators. There are some risks involved, such as risk of nausea, headaches, upper respiratory tract infection, nasopharyngitis. There's also a risk of shingles or zoster, which can be mitigated or can be prevented or minimized by shingle vaccine. Remember one thing: when you are on immunosuppressive therapy, whether this is biologics or these small molecules, you cannot take live vaccines. We have a non-live shingles vaccine, Shingrix, that you can consider before starting this therapy or during the therapy, so that you can minimize your risk of shingles or zoster. The important thing, not only in the small molecule, whenever you are selecting and discussing actually with your physician therapy options for you, the key thing is this the right therapy for you? Is this going to really help you control your inflammation? Is this the right time to use this therapy? In the small molecule category, remember that you can't use these drugs when you are pregnant or planning to get pregnant. So please discuss this with your physician when you are selecting this class of therapy to control your symptoms and inflammation. Medication considerations in children and pregnant women. Each medication has its own benefits and risk. Children require special consideration. And most of the treatment options that we have are usually being studied in clinical trials in adult patients, and then typically they are followed by clinical trials, and they'll learn about their efficacy and safety in pediatrics. So keep that in mind. Always consult your doctor before becoming pregnant, or if you're planning to become pregnant, because that may affect the choice of therapy. Most of the medications are considered safe during pregnancy, but there are some medications that must be discontinued. Some of them maybe months before you are planning to get pregnant. So please make sure that you discuss this with your physician when it comes to choice of therapy and pregnancy planning, breastfeeding, and especially also in kids, what type of medications we can use for them in terms of safety and efficacy. And lastly, don't forget clinical trials. We won't have new therapies without clinical trials. Clinical trials are ethically designed. Many offer crossover from one arm to another. So for example, if you are not responding to a therapy, many clinical trials will have an option of you going into an open label, meaning you can then actually get the drug rather than being in a blinded fashion, not knowing if you are on a placebo arm or actually getting the medication. So keep that in mind, that you may have an option where you can receive these drugs in clinical trials that may not be otherwise available to you in the market. There is Crohn's and Colitis Foundation clinical trials community that you can visit. Clinicaltrials.gov is another website where you can go and look for some clinical trials, or you can simply talk to your IBD doctor and say and discuss and explore the options of going into clinical trial. The key thing when you are on medical therapy is adherence. It could be a very complex process. A lot of factors influence the adherence to a medical therapy. The treatment-related factors, such as the dosing, could be complicated. The formulation, you may not be able to take it. The pill may be very big. You may not be able to swallow a capsule. It may be difficult for you to use a suppository or enema. The cost factor is there. You may not be able to tolerate the therapy. You may be experiencing side effects, or you may be intolerant to that therapy. Then there are some illness-related factors. You may have very severe disease. The medication may not be working for you. You'll be having more frequent flare-ups or experiencing disease complications. And all of these may be affecting the adherence to a therapy, thinking that this is not working for me, or this is working for me, so I can stop now. My symptoms have gone away, not realizing that this is a chronic disease associated with frequent relapses and remission period. I call it like a roller coaster ride, and you just need to stay 2 steps ahead of the game and take these medications to maintain the remission, not only to induce the remission, as I discussed in the very early when I started this presentation. And then there are some patient-related factors, skills and knowledge to follow regimens. Some young kids may not know, so they may need some direct supervision. Belief, psychiatric mental health illnesses. Studies have shown that male patients and single male patients, that profile of a patient may be associated with non-adherence to therapy. So we have to make sure that we address that, we keep that in mind so that we adhere to our therapy and get the maximal benefit of our therapy. What is a shared decision-making? So shared decision-making is a process where patients are actively involved in their medical decisions. It's an opportunity for patients to be informed about their treatment options and to have a say in the treatment plan. And that's why it's very important for you to learn about different options. If you're not educated, if you don't have the knowledge, then this shared decision-making process can get affected. Then you may make a decision, or you may select a therapy based on limited knowledge and education, and you may not be able to comprehend the reasons behind selecting a therapy, the treatment goals, and the preventive strategies that may need to be kept in mind, the complications that you may have to avoid by not letting your disease getting uncontrolled, and an uncontrolled inflammation that may be associated with lots of complications, including risk of cancer, losing your bowel because of the surgery, and some other complications. Majority of the IBD patients and IBD physicians, about 80% or more, prefer a shared decision-making approach. So make sure that you get involved in the decision-making process. It does increase the treatment satisfaction. It also increases confidence in the choice, and it may also improve adherence. Communication preference. While many patients do prefer to be involved in the treatment, not all patients want to be involved in making decisions about their care, and they prefer their physicians to take the lead. Shared decision-making preferences are specific to each patient. It's very important to understand how you view your health and IBD and how you would like to be involved in your treatment. Your preference may change as your relationship with the doctor evolves. In the beginning, you may have lots of questions, and with time, you may feel like that you just want let the doctor make the decision for next therapies. Your illness experiences may evolve with time, and that may influence how you want to have a preference in terms of selection of therapy, and your understanding of inflammatory bowel disease may evolve with time, and now you may be more knowledgeable, you have more education, and now you may be planning and selecting therapy in order to control your inflammation in a better way, with a better understanding also. So there are some tips about how to engage in shared decision-making process. Have an open and honest communication with your doctor. This is the key. It may not be easy always, but you just have to keep that in mind, that try your best to have an open and honest communication. If you have any hesitancy choosing a therapy, selecting a therapy, discuss that with your physician. He or she may come up with an alternative plan or to overcome an issue that may be hindering you to select that therapy. Practice talking about difficult topics with your friend, family members. So if you feel like, you know what, I cannot have this discussion with my provider, with my physician, so you may want to rehearse that with your friend or with your close family member. Make notes of important questions or thoughts about your treatment and bring that to the important. This is very important because sometimes you are in the clinic, the discussion may go to a place where you are having now brain fogging, or you just forgot what you had some questions that you were thinking of asking. So if you have written down all those questions before your appointment, so then you can keep track if you have asked those questions, and you can check those questions that, yes, I have asked all the 3 questions that I was planning to ask my doctor today. If you are unsure of your ability to communicate, bring someone with you. It could be friend, it could be family friend, for support and for assistance. And recognize there is more than one right way. There's just not one right way. And that's important for your physician as well as for you to understand. If your provider presents you with that information you don't understand, ask for clarification until you feel comfortable. You may want to get yourself a little bit of time to digest all the information that your doctor may have provided you, and you may want to ask to come back or circle back with them in the next few days or next day, and may have some more questions for the doctors, and you may just want to then communicate back with that doctor. If you're just not understanding, you may want to pause and ask for clarification. Skip over topics you feel are important. Ask to spend more time in those areas where you feel like, you know what, this is really important for me and I really want to discuss this specific issue on my visit today. And then consider making a change or getting a second opinion. So if you feel like that you are not getting a good relationship with your physician or provider in terms of discussing treatment options or getting a feedback, it is okay to change your provider. It's okay to get a second opinion. And you can even discuss that with your physician. And many of us, and most of us, and almost all of us would be okay if you would like to get a second opinion. And as a physician, if you come to me, I'll be happy to facilitate to get a second opinion so that we can make sure that 2 brains are always better than 1 brain. Maybe we can explore more options to get you a better treatment. So this is my last slide, treatment options, the key points that we learned today. Number 1, when you have a visit with your physician, it's very critical, it's very important that you understand your disease process, your diagnosis, and your prognosis. So ensure that you have the understanding, and if you do not have the understanding, ask questions to get that understanding. And then the second important key point is that know your goals of treatment. What are you trying to achieve? just the symptom control, or you want your inflammation to be controlled, or you want to prevent complications in future as your goal. And then you can select a goal with your physician and then try to achieve the goal and reassess whether you have achieved the goal or not. Symptom control and disease control are two important things, and make sure that you understand the concept of controlling symptom versus controlling inflammation, because sometimes symptoms and inflammation may not correlate with each other. You may have lots of symptoms and no inflammation. There may be other processes that may be driving your symptoms of diarrhea and pain, or vice versa. You may still have a lot of inflammation and you may just be having very minimal symptoms, or may not be able to describe your symptoms for many reasons to your physician. So understand that there could be a poor correlation between symptom and inflammation control. And we really want to control your symptoms to get a good quality of life. And we want to control inflammation to prevent complications. And then always try your best to participate in shared decision making, because that's how you will feel confident in the treatment option. You will adhere to that therapy to achieve the goal that you may have decided with your physician and selected a particular therapy. So that was it for today. Watch some of our other videos in my IBD learning session. Very confident that you'll find it very helpful so that you can have a better discussion with your physician next time you'll visit them. If you are looking for some additional support, then you can go to our website, www.crohnscolitisfoundation.org. Thank you for having me today. Have a good day.